Median arcuate ligament syndrome, or MALS, also known as celiac artery compression syndrome and Dunbar syndrome, is a rare disorder that's characterized by varying degrees of intermittent or continuous abdominal pain, gastrointestinal symptoms, and/or exercise intolerance. MALS is thought to be caused when the ligament attached to the diaphragm descends lower, or the celiac artery is positioned higher on the aorta, resulting in the celiac artery being compressed beneath the fibers of the median arcuate ligament as it passes into the abdomen. The structural anomaly can be congenital, meaning from birth, developmental, such as with growth spurts, connective tissue disorders, and lordosis, or caused by an alteration of anatomy due to abdominal or spinal surgery, or abdominal trauma. The compression can result in 4 scenarios. The first scenario is directly related to the compression of the artery, causing a narrowing of the vessel, resulting in insufficient oxygenated blood flow and nutrients for metabolic demand to the upper abdominal organs, the foregut, causing symptoms. The second scenario is called the steal phenomenon, where the celiac artery gets compressed, causing increased blood flow from a nearby artery, like the superior mesenteric artery, to get diverted via tiny collateral vessels to the celiac artery region. As a result, blood is stolen from the midgut area supplied by the superior mesenteric artery, resulting in insufficient blood flow to the bowel. The third scenario is where compression irritates the nerves surrounding the celiac artery, which includes the periaortic ganglia and celiac nerve plexus, causing chronic inflammation in that region. The inflammatory mediators, like cytokines, overstimulate nerves to keep firing and cause spasm or constriction of the celiac artery branches going to the stomach and small bowel, resulting in symptoms. This can also result in brain-stomach or neuroenteric signal disruption, causing gastric arrhythmia, leading to hypersensitized stomach pain. The fourth scenario is the excessive compression of the outer layer of the celiac artery wall, the adventitia. The adventitia is highly sensitive to painful stimulation. It's possible that the high degree of compression causes pain, which explains the worsening of pain with exercise in these patients. At a microscopic level, MALS shows fibrosis of the median arcuate ligament fibers, enlargement of the celiac nerve plexus, and a web of scar tissue within the wall of the celiac artery. Those diagnosed with MALS and who develop symptoms complain of mild to severe epigastric pain or tenderness, postprandial pain after a meal, and/or exercise intolerance. Symptoms may include indigestion, nausea, vomiting, constipation, and/or diarrhea, pulse changes, and blood pressure issues. In addition, a bruit or whooshing sound may be heard with a stethoscope over the epigastric area, which is caused by the turbulent flow of blood through a narrowed blood vessel. A diagnosis of MALS is made after the exclusion of other conditions, like chronic gastritis, cholecystitis, inflammatory bowel disease, and cardiac disease. A mesenteric duplex ultrasound of the abdomen will show increased velocity of blood flow in the celiac artery, typically more than 200 centimeters per second, an end diastolic velocity of more than 55 centimeters per second. An increase in velocity on deep expiration indicates celiac artery compression. A deflection angle greater than 50 degrees between inspiration and expiration is also indicative of MALS. Additionally, a CT scan, CTA, or MRA should be done with breathing protocols to look for the characteristic hooking of the celiac artery below the median arcuate ligament. In some patients, a traditional angiogram may be required. An interventional diagnostic nerve block may be suggested as well. Treatment of MALS typically involves surgery to release the fibers of the median arcuate ligament compressing the celiac artery. the overlying lymphatics, and soft tissue. In addition, the compressed celiac nerve plexus and scar tissue may be removed to relieve pain and other symptoms. Another option is to reconstruct the celiac artery to re-establish blood supply to the organs. In some cases, additional surgery, angioplasty, or stenting may be needed after the initial surgery. When surgery is not an option, comprehensive symptom management is needed, which may include pain management. Alright, as a quick recap. Median arcuate ligament syndrome, or MALS, also known as celiac artery compression syndrome, and Dunbar syndrome, is thought to be caused by the compression of the celiac artery and its surrounding structures by the median arcuate ligament of the diaphragm. The end result is the reduced blood supply to the abdominal organs, and/or nerve irritation resulting in upper and lower abdominal pain, unpleasant gastrointestinal symptoms, exercise intolerance, and potentially pulse and blood pressure changes. A bruit heard with a stethoscope over the upper abdomen is indicative of a narrowed vessel. MALS is diagnosed by the exclusion of other causes of similar symptoms. Specific diagnostic tests are a mesenteric duplex ultrasound, CT scan with and without contrast dye, CTA, MRA, or with the gold standard, an abdominal catheter angiogram. Treatment includes surgery to relieve the compression. Short and long-term follow-up care is recommended for continuity of care.